So I think mine is possibly the last talk here. So I've been asked to talk on lipid abnormalities or dyslipidemia in liver disease. So when people talk about dyslipidemia in liver disease, they make it synonymous with non-alcoholic fatty liver disease or NASH. So in my talk, I have therefore put NASH as the last part of the discussion. I'll be discussing more on what are the lipid abnormalities in alcoholic liver disease, the other etiologies of cirrhosis of liver, in primary biliary cholangitis, hepatitis B and C, and then lastly NAFL, and are there any contraindications of using the common treatment of dyslipidemia in liver diseases, and with a special mention on statins because there a lot of confusion always remains. So alcoholic liver disease is a spectrum of starting from a normal liver which goes into a liver steatosis, and when the steatosis combines with inflammation it becomes a hepatitis. This is followed by alcoholic fibrosis and then cirrhosis of liver. If we see in a normal liver, their lipids are basically stored in the cytosol. Their cytosolic lipid droplets are there in the liver, which is less than 5%. Mere presence of fat in the liver is not a disease. In alcohol, there is an increase in the lipid droplets, and in alcoholic hepatitis, along with the increase of lipid, there is inflammation. So how much fat does alcohol contain? So weight gain due to alcohol is possibly due to the calories and the amount of carbohydrate that it takes. Alcohol per se doesn't have fat. So it's not like that we take alcohol and we get a lot of fat from there. So alcoholic liver disease, there is a role of lipids. So when somebody takes alcohol acutely for a few days, there is something called lipophagy, which must have been discussed during the course of the day, which is basically a selective catabolism of the lipid droplets. These lipid droplets are attracted by a membrane called phagophore, which leads to a autophagosome, which is a bilayered membrane, and then the lysosomes get attached to it, and the lipoprotein droplets are inside the autophagosome, and then it undergo lysis, which is called autolysosome and lysis. And therefore, when somebody acutely takes alcohol, there is accumulation of fat, but the body's first defense mechanism is to try to get rid of the fat, and in majority of the cases, there is a resolution of the steatosis. But what happens when a person continues to take alcohol chronically? There is a prevention of this autophagic progression. There are alterations in possibly many pathways, and which leads to continued lipoprotein lipid droplet accumulation, leading to injury to the liver. Alcoholic liver disease, in addition to lipophagy, there is also an increase in the cytosolic lipolysis, and there is a decreased mobilization of lipids from the liver. Just previously, I was just listening about the triglycerides not being allowed to come inside the liver. So here it's the opposite thing, that the lipid mobilization from the liver is impeded, causing liver injury. There is also, everybody knows about the ER stress in alcoholic liver disease, which plays a major role in the mild alcoholic liver disease. The body is able to withstand it, but when people continue to take alcohol, this worsens the liver function and leads to fibrosis in the long run. So dyslipidemia, if I talk specifically of the lipid abnormalities in blood, there are very few studies. There was a study from PGI Rohtak which showed no difference. There has been a comparison of around 50 alcoholic versus non-alcoholic cirrhosis with controls. It had three groups: alcoholic, non-alcoholic, and healthy people. And if you see, when the alcoholic and non-alcoholic cirrhosis were compared, the only difference that could be noted was in the HDL values. But when it was compared to healthy controls or between the other parameters, there was no difference. When we compare alcohol with healthy, definitely we will get a difference which is expected. There are papers on patterns and prevalence of dyslipidemia in patients with different etiologies of chronic liver disease. As we know, cirrhosis may be because of alcohol, it may be because of hepatitis B, C, autoimmune hepatitis. So this was a very nice study where they assessed the cholesterol and the LDL levels of the different diseases like alcoholic, hepatitis C, and autoimmune. And they found that in all 4 of the diseases, the total cholesterol levels were a little higher in patients with alcoholic liver disease when compared to the controls. The LDL levels similarly were particularly more higher in patients with alcohol, NAFL, and hepatitis C. So what we get to know is that the LDL cholesterol levels, when the cirrhosis sets in, it is lower, but because possibly there is no matrix inside the liver. The triglyceride level did not differ. That was very surprising in the liver tissue. Despite a lower total and LDL cholesterol, we cannot say that etiology-specific dyslipidemia pattern occurs when cirrhosis sets in. And contrary to this belief that because there is a so-called improved lipid status, like a low LDL, cardiovascular comorbidities were still more prevalent in alcoholic patients, possibly because of the coexistence of when arterial hypertension or diabetes was present, there was more cardiovascular events than when a patient of cirrhosis had no hypertension or diabetes. Coming to another important part of dyslipidemia, which is very commonly seen, is in primary biliary cirrhosis. So almost majority of the patients, 75% or more, we see a very high cholesterol values. But studies have shown that this is not causing an increased risk of atherosclerosis or cardiovascular disease. This is possibly because the pathogenesis of dyslipidemia in PBC is due to lipoprotein X accumulation, and it behaves like a high density lipoprotein in scavenging some of the lipids. So this lipoprotein X impedes the chylomicron remnant hepatic uptake, and thereby it decreases the hepatic cholesterol uptake and increases the HMZ coenzyme activity, which causes accumulation of more of an unesterified cholesterol. And this lipoprotein X could possibly remove the cholesterol from tissues just like an HDL. So lipoprotein X, which is the main culprit in primary biliary cirrhosis for high cholesterol level, would have an anti-atherogenic risk. But there was a study which has shown in around 400 patients that yes, PBC still has a 12% increased risk of a cardiovascular event. This was another study which shows that despite the 76% of patients having high cholesterol, the incidence was similar. So majority of the studies, if we go through, we'll find that primary biliary cirrhosis with high cholesterol, in the absence of other comorbidities, the risk of a cardiovascular event due to the dyslipidemia was not very high. So this is another systematic analysis which shows that though PBC has a high lipid profile, the atherosclerotic risk is not surprisingly different from the general population, and it is possibly to be treated only when there is other comorbidities. Coming to an interesting part, hepatitis C and dyslipidemia. So these studies came when we started using sofosbuvir and velpatasvir, and this was an incidental finding that cholesterol was related to improvement in the sustained virological response, and those who had the higher cholesterol had a robust immune system against hepatitis C. They could not find out the cause, but they found that the ApoE mutations was possibly having a protective effect in the course of hepatitis C virus infections, and they might be one of the reasons where there is an improved response is seen. But what is more important from the clinical perspective is that many of these patients, after they have received treatment for hepatitis C, it is seen that 12 weeks after treatment, their cholesterol and LDL cholesterol levels, and particularly the total cholesterol levels, were higher, and people believe that dyslipidemia can occur after HCP treatment, but this concept needs further evaluation in a bigger study population because these are isolated reports of dyslipidemia after hepatitis C treatment. In hepatitis B, there are also some studies. This was a study of around 1,500 hepatitis B carriers who were tested for their lipid profile, and it was found that the asymptomatic carriers had a lower total cholesterol and LDL, HDL cholesterol, but when these patients' ALT level increased, then their HDL level decreased and their triglyceride level increased than patients who had a higher ALT level. The same effect was studied in another study where they showed that in a group which has a hepatitis B plus a high ALT levels, the risk of having a higher LDL value was significantly higher than people who had a normal ALT levels. Coming to the most interesting part, which everybody talks, is non-alcoholic fatty liver disease. We all know that genes, obesity, diet causes steatosis. But what causes steatosis? Because only a small fraction of these patients progress to NASH. So this part is still a mystery. And because this is not being solved, there are so many drugs in the pipeline, yet none of the drugs have got an FDA approval as of now, though obeticholic acid is just near there. Possibly there's a review meet on June where they might be possibly getting approval, but it is not without a share of problems because OCA causes increase in the lipid profile, and the pruritus is seen in around 50% of patients. And I think the government of India has approved OCA at 10 milligram, whereas most of the studies have used 25 milligram in patients with NASH. So dyslipidemia also is present in NASH, is not nothing to be debated. There is hypertriglyceridemia and the lipid profiles are abnormal. But what is important is that many of the patients of Indian origin may be lean. If you see a significant amount of patients of fatty liver are non-obese, whether the lipid profile in these patients is similar to the lipid profile in patients who are obese. So this has been studied, and though there is no head-to-head comparison, most of the studies have shown that they still have higher cholesterol levels. And this is a study on the publication from our group where we see that even though the patients were non-obese, they still had a higher amount of LDL cholesterol. We could not find a difference in the other cholesterols. This is a nutrigenetic study which is going to come up where we took the nutritional history of these patients as well as the genetic profiling. And so something beyond lipids occurs in NASH. It's not that we can control the lipids and fatty liver will disappear. Possibly the genes might matter. So if you see these two persons, both of them have burgers, but one may have a fatty liver, the other may not have a fatty liver. So there where possibly a genetic difference matters. We have identified this PNPLA3, which is different in Indian population. The SMP is different than that has been documented in the West. There is another gene called TM6SF4, which regulates fatty liver genesis. And to our surprise, we could find a regional difference in susceptibility when we took patients of Eastern India when compared to patients of Southern India. The Eastern Indian patients all had a higher ALT levels, and the genetic profiling had more of PNPLA3 positive than the people in the South. So coming to my last part of the talk is when we find a patient with dyslipidemia in liver disease, how do we treat them? So this is a guideline which has come from the American Gastroenterology Association, and it just mentions some of the things, most of them everybody knows. So what it states is that many people are afraid of starting statins in cirrhotic patients or in patients with liver disease because they believe the AST, ALT is elevated, but the Greece trial has already shown this. So the 3% benign elevations in AST is not a contraindication. We definitely need to check LFT before starting a statin, but the guideline doesn't say that we become fanatic and keep on checking LFT when a patient is on statin. The increase in AST, ALT, if it is more than 3 times, but what is important is if there is increase in bilirubin after starting statins, in the absence of a bilirubin obstruction, then we should consider that this is possibly a statin-induced, drug-induced liver injury, which, by the way, is present in only 1 in 1 lakh population, and 1 in 1 million can have an acute liver failure. They are definitely to be withheld in patients who had an acute liver failure. And other lipid lowering drugs like niacin, fibrates, which have been discussed, the cause of causing a liver injury is extremely rare. Also, we have to understand that statin is the first line treatment in patients in NAFL. We don't use statins because I want to improve the fatty liver. If statin is indicated for another reason, definitely it is to be used. Omega-3 fatty acids are also under consideration, but none is improved. And there is no conclusive evidence that any of this agent improves histology of NASH. When we talk about improvement in fatty liver, there is a very strict guideline. There should be resolution of NASH steatosis without worsening of fibrosis, or improvement of fibrosis without worsening of NASH. These should be the endpoints. ALT normalization, somebody having a lower fibroscan value, this cannot be the endpoints of any trial. And that is why most of these drugs are not getting an FDA approval, because that is the endpoint that is said. And in India, as we all know, to do a paired biopsy is very difficult. Coming to hepatitis C, there are reports of increased risk of acute myocardial infarction. So people believe that lipid profile should be monitored in patients with hepatitis C after the virus has been cleared. Hepatitis B and lipids I have discussed, but there is not much data. But we can safely use statins in patients with either Hep B or hepatitis C. The PBC, if there is an increased cardiovascular risk score, we use lipid lowering drugs, including statins can be used. I have already mentioned that obeticholic acid is a drug which has been approved for primary biliary cirrhosis and is one of the fast-track drugs for NASH. But we should keep in mind that in Child-Pugh C and C cirrhosis, we should be extremely cautious in using any of these drugs because there are reports of increased mortality. And there is no compelling evidence that statins can improve outcome in patients with primary biliary cirrhosis. Child-age cirrhosis, we should not be even worried to use statins, but with child B and child C, it is not to be used unless and until, I use a controversial statement, now statins are being studied to reduce portal hypertension. It has been used as an anti-portal hypertension drug. So things might change in the next 1 or 2 years when the studies on this from Mayo Clinic comes up. Finally, if we see dyslipidemia can occur even after liver transplant, which we call as a post-transplant metabolic syndrome, because the patient starts feeling well, they start eating, they don't exercise. And even in this category of patients, we can safely use the lipid-lowering drugs, but we may keep in mind that the calcineurin inhibitors, there may be a risk of more statin-induced myopathy in this category of patients, which is definitely not seen in parvastatin and fluvastatin for discussion because they're metabolized through a different pathway. So finally, dyslipidemia is a common in liver disease, and we should investigate every liver disease for a dyslipidemia. Wherever necessary and indicated, standard treatment of dyslipidemia are possible. There is no definite contraindication of use of statins unless we are dealing with somebody with child B and child C cirrhosis. Hepatitis C patients, even after they clear the virus, needs to be monitored for development of dyslipidemia. The exact mechanism is not known. Not all PBC dyslipidemia have increased cardiovascular risk, but this must be treated if indicated. NAFL patient needs treatment as most have metabolic syndrome, and lean NAFLD may be a different class which may or may not benefit, but if their lipid profiles are abnormal and as per the standard guidelines they need treatment, they have to be treated for this. So this is what I could summarize on lipids in liver diseases.